And what I want to do is provide some perspective from a medical oncologist. I think we've heard from a number of surgeons about their perspective of treating localized or locally advanced disease. And so I think we're all quite familiar in terms of when we think about the resection categories for pancreatic cancer. We have patients who really are upfront, appear to be clearly resectable, and then at the other end of the spectrum are patients with locally advanced unresectable disease who, frankly, even with the best of our systemic therapies, are not likely to be able to undergo a successful R0 resection at any point. And then we increasingly recognize this, I think, fairly unique and distinct category of patients with borderline resectable tumors that are now the subject of their own specific trials. Now, for locally advanced disease, just in terms of broad strokes, we generally give chemotherapy with or without radiation afterwards. Patients with borderline resectable disease, again, neoadjuvant treatments, and then ideally taking them to surgery after a still controversial duration of systemic therapy, again, with or without radiation treatment. And then, as has been shared by previous speakers, the traditional approach for patients with clearly resectable disease has been upfront surgery and then give them adjuvant treatment afterwards. But as we think about changing paradigms, I'd like to make the argument in terms of why, even for this group of patients, we can and should be thinking about starting them with systemic therapy before consideration of an operation. So let me take you through this. When we think about and when we look at data from adjuvant trials, really this already is a very carefully selected group of patients who enroll on trials. So if you look at a denominator in terms of all patients who are taken to upfront surgery, you do have a proportion of those patients who are unresectable, found to be unresectable in the OR. And then even those who are able to undergo an R0 or R1 resection, you have a proportion, 20-25%, who just are not able to recover adequately to be able to receive adjuvant therapy. You have some who are fit enough, but at restaging, unfortunately, are found to have metastatic disease and drop out. So really, at the end, the patients who are eligible for participating in these trials, the numerator, ends up being only maybe 50-60% of the original starting number. And I think that should give us pause for thought. Now, I don't want to talk too much in detail because I think this audience is already pretty familiar with the adjuvant regimens. Just to review very briefly, we've seen an evolution going back to the original CONCO-001 trial that established chemotherapy, namely gemcitabine, as the standard of care. And then over the successive years, we've really had results from both SPAC4 and then the Pradesh study that have really shown significant improvements with combination therapy compared to single-agent gemcitabine. And I haven't even highlighted here the S1 data from the JASPAC trial that our Japanese colleagues now use as the standard of care with their oral S1. Again, just as a reminder, the Pradesh study that established modified FOLFIRINOX as a standard of care is really for the very fit patients. And I think the striking results from this study showed that for those patients who underwent a successful resection and were well enough to get FOLFIRINOX, the results were really quite striking in terms of when you look at the survival curves. Again, as was pointed out from previous speakers, having a median survival of 54 months. So really a higher proportion of patients, I think, who are being cured with more effective systemic therapies, I think really does indicate where we're going in terms of this current era where we have, thankfully, newer and better treatments. Now, later on this morning, we're going to do an encore presentation of the APACT trial results, and you'll hear a little bit about gemcitabine and nab-paclitaxel as a combination. And so I won't go over that in too much detail. And then what I'll finally note is what is still really an unresolved question, but hopefully with a cooperative group trial, RTOG 0848, ideally this will settle once and for all this question of does adjuvant radiation treatment improve survival in this patient population. And we know earlier data from European studies suggested that radiation perhaps is not beneficial, but with current treatments, we will hopefully be able to get a sense of whether radiation does anything beyond improve local relapse rates, or whether it really has any impact on patients' longevity. Now that moves us to this question of neoadjuvant therapy. And I'm not talking about neoadjuvant therapy for those patients as described by previous speakers with bulkier tumors where there's clearly partial mesenteric involvement, et cetera, but really for those who appear to have clearly resectable disease. And a previous speaker highlighted, I think appropriately, a number of the putative advantages of giving treatment in that neoadjuvant setting in terms of having an in vivo assessment of the effectiveness of treatment. What I view it as is you're getting both positive selection in terms of patients who are most likely to benefit from a subsequent surgery, as well as negative selection, those patients, which really amounts to anywhere from 10 to 40% who are going to develop metastatic disease and not benefit from surgery. And that really gets to what I would view as the argument against the using neoadjuvant therapy. I don't think this idea of losing your window of opportunity for curative resection reflects the true biology of this disease, meaning those patients who do develop metastatic disease during that neoadjuvant window are likely those patients who are not going to have benefited from an upfront surgery. I think it says something about the biology of the disease, and what we want to do is avoid taking those patients to surgery who really are not or would not have ever benefited from undergoing such a large operation. Now, I think we're faced with some challenges in terms of neoadjuvant treatment for operable disease, and that includes historic biases, referral patterns, and this is true for our institution at UCSF, and I think we're starting to see a shift in terms of even what our surgeons think in terms of patients who seem to have operable disease, sending them our way. But if you look at this, I think pretty interesting study, just polling surgeons and oncologists in terms of their preferred treatment approach for, say, a patient who has clearly operable disease, you see that the vast majority of providers are still viewing upfront surgery as the standard way to go. But I think we have now mounting evidence in terms of neoadjuvant treatment as an appropriate approach for patients certainly with borderline resectable, but even for truly resectable disease. And I highlight here this Dutch study that was a phase 3 study, and again, it included patients with both resectable and borderline resectable disease. The details of the actual treatment are perhaps not that critical. This was just a gemcitabine-based regimen. But as presented at last year's ASCO meeting, what you saw from this study, the investigators reported that, yes, the R0 resection rate was lower, and I think that's appropriate. You're basically selecting out those patients who really probably should not have undergone surgery in the first place. But when you look at the R0 resection rate, clearly higher in those patients who received neoadjuvant therapy. And then these survival curves don't tell the whole story, because you look at the median overall survival and disease-free survival, and overall survival, there's perhaps a trend towards improvement in the overall intent-to-treat population. But what I don't show here is the graph for those patients receiving neoadjuvant treatment who actually did successfully go on to surgery. The difference in survival compared to those who were taken to upfront surgery was about 42 months versus 16 months. So a very, very large difference by carefully selecting out those patients who were most likely to benefit from an aggressive operation. And then at one of yesterday's symposiums, Dr. Uno presented updated results from this Japanese cooperative group study that, again, I think changed or is changing the standard of care even in Japan, basically showing that a neoadjuvant approach in purely resectable patients does seem to confer improved survival compared to upfront surgery followed by adjuvant chemotherapy. Now, I want to highlight just a couple points regarding some of our U.S. National Cooperative Group studies. This SWOG trial is basically a comparison of different perioperative chemotherapy regimens, FOLFIRINOX or gemcitabine nab-paclitaxel. And while we don't have the final readout of this study just yet, I think perhaps the most relevant point that's been presented so far is that almost 30% of patients who were enrolled on this study who supposedly had resectable disease actually on QI analysis afterwards actually were not eligible. They either had more locally advanced tumors, again, evidence of arterial, venous involvement, or even metastatic disease that rendered them really ineligible for this study. And then I'd like this audience to be aware of and stay tuned for a very large cooperative group study that we're just about ready to get underway. Again, this is for patients with truly resectable disease, and this is really looking at with contemporary chemotherapy, namely FOLFIRINOX, whether preoperative FOLFIRINOX followed by surgery confers any advantage over upfront surgery followed by the standard adjuvant FOLFIRINOX. So again, we're expecting this study to get underway likely in early 2020. Then the last few minutes, I actually do want to talk about patients with more advanced, so either borderline resectable or locally advanced disease. And from a medical oncologist perspective, I think what I can say in terms of a truism is that I do think that starting with systemic therapy in these patients is appropriate. And I think that's probably widely accepted amongst the community. Things that have been alluded to before in terms of what the optimal duration of chemotherapy is. Our institutional experience, for example, at UCSF involves up to a 6-month course of chemotherapy, typically with FOLFIRINOX if possible, before these patients undergo surgery. And as I'll show you briefly, we don't find that radiation necessarily enhances our results. But really, identifying those patients who would then be appropriate to take to surgery following neoadjuvant treatment can be tricky. And certainly there are probably radiologists in the audience who can speak to this better than myself, but the post-treatment findings may in fact overcall the extent of residual disease, and that's been shown by groups at MGH and elsewhere. And so we may be leaving off the table some patients who may in fact benefit from surgery at a later point. In terms of borderline resectable disease, again, this highlights an issue in terms of needing real-time central adjudication of imaging to really define, because I think we all see the subjectivity and what has been pointed out before in terms of a surgeon's willingness or even interpretation of what is truly resectable or not. There is significant disparity as far as that goes. Again, the Alliance Cooperative Group has taken the lead on borderline trials. Matt Katz at MD Anderson has really invested a lot of time in demonstrating the feasibility of studying this specific subgroup of patients. And what I'll show here is the borderline resectable pancreas trial, the results of which are still pending. Again, looking at, for borderline resectable patients, using neoadjuvant FOLFIRINOX with or without radiation treatment. I just want to point out briefly some UCSF data that we looked at in terms of our patients who are treated with neoadjuvant FOLFIRINOX. And as highlighted by the previous speaker, I think it's important to point out that there's really quite a bit of disparity in terms of the degree of pathologic response that's seen. And again, this is chemotherapy only, so no radiation. So just look at the left-hand columns. But what you can see here is in terms of patients who had significant regression of their tumors, either by Evans grading or by the College of American Pathology in terms of degree of residual tumor or how much cell kill you're getting from neoadjuvant treatment, you see that a substantial proportion of patients are achieving actually a very good pathologic response. And I think that's important. And this just shows some histopathology from representative patients where you can really see, starting from panel A, where you've got basically very little cell kill, all the way to D, where you have a very robust response, where there might be just a few scattered cancer cells left. And is this relevant? The answer is absolutely, as we might intuit. If you look at the survival results, again, from our experience, you see that patients with a more profound pathologic response by either CAP score or Evans grade do seem to have a significantly improved outcome. Now, this still belies the question of what do we do for patients with a poor response. These issues of should they receive adjuvant therapy, should they switch treatment at that point, these are still some elements of the unknown that we in the medical oncology community need to grapple with. Finally, I'll just note that this presents a nice opportunity for us to look at novel therapies. So we've talked a lot about the standard chemotherapies, and appropriately so, but I think we do have opportunities in these patients to do either what are called window of opportunity studies or regimens where we're layering on additional treatments to our standard treatments. And I'll just, by way of just a couple of examples, I'll just show you, because there are not that many studies that are dedicated specifically at looking at novel agents in this preoperative, resectable, or locally advanced setting. So example one is a drug called pamrevlumab, which is an antibody directed against the activity of connective tissue growth factor, and presented at last year's ASCO meeting, suggested some promising activity in terms of downstaging those patients with initially unresectable disease to be able to undergo a successful R0 resection. So this is the basis of a planned phase 3 trial. And then I'll also highlight an example from our colleagues at Massachusetts General who have done some really nice preclinical studies in terms of losartan and these angiotensin receptor blockers. And what I didn't know previously was that this class of agents actually is important in terms of mediating TGF-beta signaling, which is very important in terms of this dense desmoplastic stroma that we're all very familiar with in terms of contributing to, in terms of the pancreatic cancer microenvironments. And the phase 2 data that this group presented showed that the addition of losartan to standard chemo and radiation seemed to successfully lead to downstaging in patients, again, with initially unresectable disease. And so this is the basis of a larger randomized trial looking at losartan with or without immune checkpoint inhibition. I'll say parenthetically, for those who are interested in stromal biology, I think these sort of approaches in terms of targeting the stroma and things, we have to be very cautious. Now hearing recent results from the pegylated hyaluronidase, yet another example of where perhaps a stromal modulating approach may not be as beneficial as we had previously hoped. But these, again, just demonstrate a couple examples that I wanted to highlight in terms of how we can take some of our novel discoveries and how it might be useful in terms of looking at the on-target effects in this preoperative or locally advanced setting. So in conclusions, I hope I've shown you that aside from adjuvant FOLFIRINOX, which again is an appropriate standard, that we can and should be thinking more and more for all of our patients the use of neoadjuvant treatment. Borderline resectable disease being kind of its own unique entity with a number of outstanding questions in terms of selection, duration of therapy, role of radiation. And then finally, seeing this as really a good opportunity for investigation of new agents in the pre- and or post-operative setting, as well as the possibility of long-term maintenance treatment in these patients to increase the likelihood of cure. So with that, I'll thank you for your time. I want to thank my family. I want to thank Dr. Tempero and all of my colleagues at UCSF and the Pancreas program, and thank you for staying to listen to my talk.
Time for one quick question.
Yeah, so thank you so much for one wonderful presentation. So I have two questions. I'm sorry.
One question.
So the first question would be, okay, yeah. Right. So if you see patients with resectable patients with major response to neoadjuvant therapy, will you provide adjuvant therapy for them, and how? Thank you.
Yeah, so that's obviously an outstanding question that we don't know the answer to. Our preference, as I mentioned, is to front-load patients with their chemotherapy. Now, we don't do the 11 months as previously. I don't know many patients who could really receive that much treatment with such a regimen like FOLFIRINOX. But we really try to give, say, a full 6 months of treatment, thus allowing them afterwards to recover without necessarily needing more treatment. I think the bigger question would be those patients, not necessarily who had a major response, but those who didn't. And we have, again, some patients who show little treatment effect, if at all. we see that in our data that those patients don't do as well, and the question is, does it make sense in those individuals to then pivot to a different regimen such as a gemcitabine-based regimen? So I think that conceptually makes sense. Whether that really bears out, we don't yet have the data, but it's a very important question you're raising.
Okay, thank you very much.
Thank you.